we are not exposed to something new in content, but we are exposed to something completely new in terms of experience. Now, when we were abroad, when we were in our university teaching hospitals, the systems, the functionality, how things went were completely different. Sometimes there might be some similarities, but most of the time, the setup here is completely different. Unless we have worked as pre-interns here, the setup will be very new. So when we went to internship, there were many things we wish we knew before. There were many things which we wish that we should have mastered it before. We had to learn it in the due course, and then it depends on what stations you get, and it all depends on the luck of what sort of seniors you are with, what sort of colleagues you get. When considering those facts, some people might have a really pleasant experience, some people might not. So let us just share our experience so that you will get an upper hand on how to deal with internship and how to start internship fresh with a perfect mindset. So as far as I remember, you all will start your intake on the 1st of May. Right. So I will be doing medicine and surgery. Dr. Sumaiya will be doing Gynecological then, and then Dr. Kaushini will brief you on Pediatrics. So those are the 4 main disciplines which you will be doing your internship. Out of that, you'll be selecting only 2, 6 months in one, 6 months in the other. Right. So let me just share you my screen. All right. Right. So internship is one important cornerstone of your career, especially in Sri Lanka. Getting through internship is, how do you say, the moment you finish your 1 year of internship, the experience you gain, the self-confidence you've gained through this 1 year, that itself is enough for you to go anywhere in the world and handle any sort of patients. And I can guarantee you on that, because as interns, although we are named as interns, the workload we go through in Sri Lankan internship is much complex than other countries. Right. So the main question comes as to what and how to choose. Right. Let me, okay. So now when considering what and how to choose, now the number one is your station. Now there are many ways how you can choose a station. Now there are some factors which you can't help, because anyways we come in the common merit, so we usually come much below, but still that's nothing to worry. All stations are good. I'll just explain you the various stations and what are the pros and cons. Now you got teaching hospitals, you got DGHs, you got base hospitals. Now these are the stations you will be getting throughout the country. You will be going to either a base hospital or a tertiary care teaching hospital. Now in a base hospital, you will be working right under a consultant and an SH and some SHOs, senior house officers. In a teaching hospital, on the contrary, you will be working under a consultant, senior registrars, SHOs, and then you guys. On top of that, if it is a prof unit, you will have someone to help you, like shadow HOs. you'll have finally a prof unit students, so that they will be shadowing you, they'll be helping you out in stuff. So yes, now we being in the very bottom of the, we being in the very bottom of the merit list, now we are very prone to get stations somewhat in the periphery, not always, most of the time. Let me first talk about periphery. Now, when choosing a station, number one, you have to always consider your, the distance from your house. Now, it depends. Now, if you are willing to, if you are married, or if you want to take your parents also to the place where you work and, rent a house there or annex a place there and stay there, then the station selection doesn't matter. But if you are a person who really wishes to stay near your house, then I think you should choose a station which is more nearest to your house. If not, let's say you did not have a take in the choice, you had to go through the merit list and you somehow happen to choose some periphery, which is very far away, where traveling on a weekly basis is completely out of choice. So then the next thing is that base hospitals. Now, base hospitals, as I told you, you will be under a consultant. You will be under a consultant, and you will be under an SHO. So here, what happens is that you will be the first person. You will be the first person as house officers to encounter emergencies. So you will have an upper hand in managing emergencies. So at the end of 1 year, you would have seen more emergencies than anyone who had worked in a tertiary care. Because in a tertiary care, there's a well-versed ETU with emergency consultants, emergency medicine SRs, emergency medicine registrars. They will go handle the emergencies, stabilize the patient, and then they will call the ward registrar and tell this is the situation. The registrar goes to the ETU, sorts out the situation, triages the patient, and gets the patient to the ward. And finally, when the patient is coming to the ward, sometimes he would have been on a non-invasive ventilation, he would have been on a CPAP or a BiPAP in the ETU. By the time he comes to the ward, he would be already on a face mask or even on room air. So it will be all a retrospective experience in a teaching hospital. But the upper hand in the teaching hospital is that you get a wide variety of cases, because that being the teaching hospital with all subspecialties and all sorts of facilities, you get all patients coming through all different parts of the country. So there's a wide variety of cases, and one upper hand is you can learn. It's academically amazing to work in a teaching hospital, especially if you got PG plans. It is an amazing method to start studying, because you got registrars, you got senior registrars. There is a continuous medical education going on. There is a continuous teaching process going on in a teaching hospital. So that is there. But on the contrary, to an HO in a teaching hospital, the workload is somewhat higher, especially if the ward is shared by 2 to 3 consultants, like in a prof unit. Sometimes the consultants come in various times. You might have no clue. So whenever they come, you have to go do rounds with them. You have to be ready at all times. There's no particular time where you can go out of the ward, and there are so many specials to be done. I'll explain you what are those specials and stuff. So that's how a teaching hospital runs. But in a base hospital, the setup is quite simple. You do the rounds, and then the SHO does the rounds, and then the consultant does the rounds, sorts everything out, and then you are left with the patients and the ward. And most of the time, you will be some sort of alone in the ward managing the patients in some peripheries, not all, some peripheries. So here, cardiac arrests, acute pulmonary edemas, acute fitting episodes, status epilepticus, all sorts of acute emergencies, you will get the upper hand in witnessing it, managing it. Especially on example, if you take a base hospital somewhere in the eastern province or the northern province, the HO there would have seen thrombolizing a myocardial infarction many times, but an HO in a teaching hospital would have never seen, because the moment they come to the teaching hospital, they will be taken over by the cardiology unit. They thrombolize it, or they thrombolize it in the ETU, sort out everything and send. So it's just, a matter of clerking, where you read and, retrospectively get to know that this is what happened. There are perks. Now, there is some skill which an HO has to gain throughout this process, which I'll be explaining in the due course. So station, when you're selecting a station, I don't know if the station selections are already done, but the basic idea is, number one, think what is your preference. Do you need to be closer to your house? Then choose a selection, choose a station closer. If not, if that is not one of your criterias, there are two ways where you can think. Either you can choose and opt to gain more academic experience and go for a higher grade hospitals like a teaching hospital, or you can choose, no, I want to get hands-on skill experience and go to a base hospital. So that is how the thinking pattern should work. Next is the appointment. Now, when talking about appointments, you have 4 appointments: medicine, surgery, gyn, speeds. Now, there are 2 surgical appointments, 2 medical appointments. Medicine and peds come in a medical track. Surgery and gyn comes together. Now, you either can choose. What happens is, you either choose one subject, one discipline, like medicine and surgery, or medicine and gyn, or pediatrics and surgery, or pediatrics and gyn. So that is how you should choose. Now, how do you think what you have to choose? Now, that depends on what you want to specialize in, what do you feel like to be. Now, if you want to do medicine, it is best if you could do medicine for your internship. If you want to do pediatrics, it is best if you could do pediatrics in your internship, because that 6 months will give you abundant experience. That 6 months will give you abundant experience, so that when you are an RHO and when you are preparing for the exam, you won't need to worry about gaining some sort of a work experience, because you've already had 6 months. And most of the prospectors have made it a requirement that you should have a particular time period in that particular field. Like for medicine, it's a must that you should either do 6 months of internship in medicine, or either 6 months of RHO period in whatever subspecialties of medicine. So that is how you choose appointment. So is my screen stuck, guys?
Yes, Ishfak, it seems to be stuck.
All right, wait. How about now? Let me just stop sharing and share it again. Right, now is it okay? Is it, do you see me? Right, just let me know in case the screen gets stuck again. All right, so I hope you all were listening to what I was talking about. So what and how to choose, mainly the station and the appointment. Those are the 2 main things what you have to focus on. Now, to think about holidays, to think about vacations, to think about, okay, going on trips. It's better if you don't have those expectations. Some stations you might be lucky that you might get vacations to go home and come. Some stations you might not. So just imagine yourself that you are going through 1 year of some rigorous training process, so that after 1 year you'll be having the liberty to go around here and there. So some qualities to develop by the time you start your internship. Most important thing is being humble. So this is what I learned in my internship. Now, being humble actually takes you a lot far. What I mean by being humble is that, when you are a house officer, so you are the team lead in the ward. So you will be the one to spend the majority time in the ward. So during that time, apart from the times when your senior comes for rounds and stuff, you will be the team lead. But being humble, you will be able to get, the upper hand of support from your staff, not only from the nurses, not only from the minor staffs, even the janitors. So that being humble will help you a lot in taking your internship that 1 year smooth. Next thing is being punctual. Now, consultants usually come by 8:30, maximum 9 for their rounds. Before that, the SHOs, registrars, they come and do the rounds. So we need to make sure as house officers, we need to be punctual. We can't be coming to the ward after the registrar comes, because the registrars are under pressure that they have to see and sort out the patients before the senior registrar comes and the consultant comes. So since we are down in the line in the hierarchy as house officers, we have to be punctual, we have to be on time, right? So we being punctual, makes our character such that among nurses and the other staff, we will be highlighted. Okay, so being punctual is very important. Next is being responsible. So what I mean by responsible, now let's say you have some patients in your ward which are critical. Now let's say things like dengue, that's some business which you should not mess with. Right, that is some business which you should not mess with, dengue. Now, being responsible in the sense is that it's something like being accountable. So you need to make sure that you are taking complete responsibility of the patient, making sure that that patient is your priority, and making sure things happen to that patient. It's not just a thing like office work where you clock something, just do something in your computer like, okay, fine, tomorrow morning I'll just come and sort it out. No, it's not like that. This is something with life. So then and there things have to be sorted out, and you should have that sense of responsibility. Next is being confident. Most of the time, there are many occasions where we lack confidence, because sometimes that may not be the first time we are dealing with things. So being confident is very important. Being confident is very important because it gives you upper hand, and the nurses and all, they might like when you are confident, they see it in you, like the decisions you make, the management you give, from the confidence you show, they get an idea about your knowledge, they get an idea about your experience, and they somewhat put a score on you on their minds. So being confident is very important. Next, the most important thing what we fail to do is CME, continuous medical education. So your medical education did not stop at your graduation. Your medical education did not stop at your ERPM exams. You have to continuously keep reading. You need to continuously, because things keep changing. We have been knowing that metformin is the first line drug for diabetes for all these years. But 2023, the American Diabetic Association have changed everything. Now, metformin is not the first line anymore. It all depends whether you have your cardiovascular risk or renal risk, whatever. GLP-1 analogs, SGLT2s, now they have come first line. So, you need to improve your continuous medical education. So the things you can use Medscape and you can use UpToDate. Now, Medscape is completely free. UpToDate is not free, but you can go to Better Evidence Program. Just type it on Google and go to Better Evidence Program and apply for a scholarship where they give you free subscription to UpToDate, so that you can read latest up-to-date management practices and guidelines. So I know you won't have time to read, but like, let's say you get a case of status epilepticus and there will be some time where you are sitting around, just read about status epilepticus. Now, what is happening now? How have we managed? How are we supposed to manage? Should there be something else be done? What are the investigations I need to send more? So things like that. So continuous medical education is very important. Now, the fact, always try to impress your boss. Now, this thing should happen without conflicting your co-HOs. You will have co-HOs. Now, everyone will try to impress your boss. Now, this is not something egoistic where you compete with your HO. But you should always try to impress your boss, because gaining the goodwill of your boss reflects in a much better manner in terms of when you're going for your postgraduate studies. So always try to impress your boss by being perfect, by being an HO how he wants you to be, but without conflicting with your co-HOs. Respect every single staff member. Now, respecting every single staff member, it doesn't matter if it is a nurse or a minor staff or a janitor. You have to give them their due dignity. It doesn't matter you being a doctor. You have to respect them. You have to respect their age. Now, that is a very good. Now you being the youngest person in the ward, but the team lead in the ward, the minor staff might be so much elder to you, but he would be still calling you sir. But you giving him the due respect for his age, will impress their minds, and it'll reflect in a very nice way. At the end of internship, you will realize that. Next, learn from anyone at any time. It doesn't matter. Example, I learned most of the emergencies, like how to manage them at that particular time, even in terms of defibrillating a patient, from the nurses. So there's nothing to be shy of. You can learn from anything. I mean, you can learn from anyone, anything at any time. So be ready to learn and don't be shy to say you don't know. It doesn't mean that you should say you don't know and escape and run away from it. You should always go front, but you should not fear or be shy to say you don't know, but you learn it. So you'll face it, because there's always a first time for everything. So these qualities should be developed before you enter internship, so that your internship process will be smooth. Now let's quickly go through the medical appointment. Now, in the medical appointment, you have the male ward and the female ward. So each male ward and the female ward. Out of the male ward, you have some beds dedicated for HDO, which is the high dependency unit. Some beds are dedicated as the acute side. Some beds are dedicated as the subacute side. Some beds are dedicated as the chronic side, and most of the wards have something called the floor beds. Means the patients can be on the floor, under the bed, near the balcony, on the stairs. So that applies to the female ward as well. So you being an HO, sometimes you will be sharing the ward with 2 or 3 HOs. So you will, in that 6 months, you will have to divide yourself out of that 6 months. You should at least do 3 months in acute and HDU and 3 months in this. So that division of rosters, you have to sort it out once you go there with your co-HO. So this is the basic setup. Now, apart from this, there are clinics to run. I'll talk about the clinics later. So one important thing, very important thing is how to clock. Now that is one important skill. Now, BHT is a legal document. You should always remember that. In terms of litigation issues, in terms when there is an issue where the case is brought up and it goes on for something legal in the courts, BHT is considered a legal document and every page is an evidence, right? So always start with the name, your name, designation, date, time. Make it a habit. Do not miss it, because like as a registrar, like now when I work, I sometimes get irritated when the HOs clerk without the designations and without the time, because retrospectively you don't know what happened, you don't know what happened when. So always make it a time, to make it a habit to start with your name, your designation, date and time. Always make it a habit, so you will be safe. Sometimes there might be occasions where you wouldn't have written the time, but you would have attended the patient earlier. But when things did not go your way and it ends up in an inquiry, there won't be any way to prove that you were there on time. The only way to prove is your BHT. So make it a habit. Next, write clearly. You don't have to have pretty handwriting. You don't have to have very glistening, round, circle, pretty handwriting. Just write clear so that people can read. Do not make your handwriting very haphazard and random. You have to make sure that everyone is able to read your handwriting. So write it clear. If your we all don't have perfect handwriting. If our handwriting is bad, make sure we write in block letters, right? Always treat the BHT. You should treat the patient, yes, but treat the BHT more importantly, because that is a legal document which will save your life, in terms of save your life, save your career. Always develop a dynamic problem list during your rounds. I'll just explain you what is the dynamic problem list on the next slide. And always have a working diagnosis. An HO's job is not to just come and say, okay, what are the complaints? What is the BP, blood pressure? Okay, continue the same, senior opinion on management. That is not why you are there. Any clerk can come and do that. You are something better. You are a doctor. You have an analytical thinking capacity. So you need to have a working diagnosis in your mind. So you have to have that in your practice to, whenever a patient comes with a complaint, always have differentials in your head, like what could this be? So write down your differentials, right? Have a methodical way of clerking. Don't be haphazard. So for example, like so I used I as my designation, and I use 7 a.m. on the 20th April 2023. So this is how I start. And then like 84-year-old. So first I write their background: hypertensive, diabetic for 10 years on oral hypoglycemic agents and dyslipidemia. Now complained on chest pain, which is suggestive. I'm not writing the history taking, I'm just telling you how I write during my round. So came with a suggestive type of chest pain. ECGs were dynamic. So we are treating for a acute coronary syndrome pending TROPI. So this is an amazing summary which shows what is happening to the patient. So it's an 84-year-old, you know the comorbidities the patient is having, why the patient got admitted, what are you treating now and what are you awaiting if you have sent some investigation. And then you go through your examinations, you jot down all the necessary things, the examinations perfect now because you've been through the ERPMs, you mastered examinations. And then finally you give your plan. So plan can be investigations, it can be a management. So always write them separate so that the nurses can see it clearly. What are the investigations? What are the managements? So have a habit to clock better and always have a dynamic problem list. Now, what I mean by dynamic problem list is sometimes when you're working in the chronic side, they can have multiple problems. They can have an acute coronary syndrome. They can have an ongoing sepsis. They can have an electrolyte abnormality. They can have some ongoing seizures. They can have a stroke. Now, they can have 5 problems. Now, when the patient is staying for like around 6-7 days, you need to always make it dynamic. So now what is happening with sepsis? Now, what is happening to the MI? Now, what is happening to the electrolytes? Every day morning, this is what you have to see. So this is what you have to do in your rounds. This is what I mean by doing rounds. Next, you need to, for all the appointments, whether it is medicine, surgery, gyn, obs, peds, knowing the emergency trolley is utmost important. The first day you go to your ward, go explore your emergency trolley. Make sure, make yourself comfortable and know what and all are there in your trolley, right? So this here is the emergency trolley. I mean, this is a fancy setup. Most of the hospitals may not have this. They might just have a simple trolley or a collections of boxes for an emergency trolley. So this is the trolley in our ward. So you need to know the important drugs and when to use them. I'm sure by now you know medical emergencies. I'm not going to go through them, but it is very important that when you are doing your internship to have them written either in your phone or something. I normally keep things in my phone because I don't remember doses. It's very difficult for me to remember numbers, so I always keep it written in my phone. Example, in terms of paracetamol poisoning, how to give NAC. I can't remember the entire infusion management plan of NAC, so I keep it written down. So whenever I have something, I quickly refer and then write it down. So the drugs in your trolley, you should have furosemide, Lasix, calcium gluconate in case of hyperkalemia to stabilize the heart, in case of seizures due to hypocalcemia, then amiodarone in terms of arrhythmias, in terms of ventricular fibrillations in cardiac arrests, and then epinephrine, the most important thing in cardiac arrest and in anaphylaxis, and you need to know how to use them, like in what dilutions. This is coming in 1 in 1000, 1 ml. So for anaphylaxis, how much should you give? For cardiac arrest, how much should you give? What is the dilation? How to dilute? Those things I'm sure you would have learned by now. So just revise them. I normally took my emergency medicine notes with me to my internship. So it's better if you all could take it too. Next, you'll always have flumazenil in case of a benzodiazepine toxicity. Sometimes we give benzodiazepines to sedate the patient, and sometimes they might go into respiratory arrest. You might need flumazenil. Hydrocortisons are important in allergies in terms of bronchial asthma, COPD. Sodium bicarbonate is very important in treating metabolic acidosis. That also depends on the cause. Then you have magnesium sulfate, especially in gynecology. You need magnesium sulfate for eclampsia, eclamptic fits, and especially in medicine in terms of arrhythmias and in terms of bronchial asthma management, acute severe asthma. Atropine in severe bradycardias. Sometimes you might deal with carnero poisonings. Sometimes you might deal with OP poisoning. So you need to atropine the patient, make an atropine infusion. So atropine is very important. Then adenosine. Adenosine is also important in terms of SVT. So SVT is adenosine is very important. Dextrose. Hypoglycemia is one of the most common killers in the ward. So don't let any of your patients die with hypoglycemia. That is a shame. The moment you see something abnormal happening in the patient, no harm. Check your sugars, because hypoglycemia can present in any way. So that is very important. Next, dobutamine. So now when the patient goes into shock, you need inotrope. So there's dobutamine, there's dopamine, there's noradrenaline, there's adrenaline, there's vasopressin. So you need to know, I mean, the doses your seniors will tell you with time, but you know, these things should be there in the emergency trolley, and you as HOs, you are the team lead, you need to make sure that these things are there in the ward, that the emergency trolley is ready, that when there's a cardiac arrest, you are the team lead, you take over the scene, you give the orders. So you should build that character on you. So that is what is expected from an HO. Rather than a person freaking out, I know your first emergency, your first cardiac arrest, you will freak out to the core. But what I want you to learn from that experience is the next cardiac arrest, you should take charge. You know, always have a method, have an algorithm in your head and follow your algorithm, so that you don't stray away. So that is how you develop your confidence in managing emergencies. So dobutamine, very important. Then you have dopamine. Then dextroses, there's 10% dextrose, 50% dextrose, 5% dextrose. So those are used for hypoglycemias. Next is midazolam. Midazolam is one of the most important drugs, which is used either in curbing down seizures, or sedating them, or even preparing them for intubation, like for a rapid sequence intubation. Next is cassia, hypokalemia. You need to give them, replenish them with potassium, because hypo or hypokalemia they will be prone for cardiac arrhythmias. So this is how the first drawer would look like. So I have shown you individual pictures of all the drugs. So an emergency trolley should have these things, but you know, due to some unfortunate financial crisis in the country, there are some drugs which are not available, sadly, but still these are the most important things what you should have. Next, intubation. Always make sure that the battery works here. Always make sure you check it and see if the batteries are working. No point when you're finding it for intubation and oh, the battery is not working and the light's not working, and then you're panicking trying to find a battery. No, that should not happen. So always make sure that the batteries are functioning. So this is how connect it and make sure the lights are working. So then you have the laryngoscope blade box, you have ET tubes in various sizes, you have oropharyngeal tubes, you have extra batteries, you have these lignocaine gels, you have LMAs. So this is the drawer for airways. So you need to make sure that these are there, so that in terms of emergencies, in terms of planned intubations in your ward, these things should be there in your ward. So if they are not there, ask your nurses. Tell your nurses, Miss apita me LMA එකක් නැහැ, අපිට LMA එකක් ගෙන්න ගන්න පුළුවන් වේද? So they will get it from somewhere and put it in the trolley. So as a team lead, you need to be stern on that. Next drawer, there are all syringes and cannulas, three-way taps, plasters, ECG leads, and then you have the ambu bag, you have the dextran, and you have these burette sets. Like burette sets are devices which you take around 100 to 200 ml separately, so that you dilute drugs and give them as slow infusions. So dextran is very important in terms of dengue. I'm sure you all are experts in dengue by now, because dengue is very common, and dengue is one reason where the HO also can go into an inquiry. Dengue, maternal issues, and blood transfusions. Be careful with those three. So this is what I meant, the burette set. So just when you go to the ward, learn it from the nurses. Like Miss, there's a way how you get the fluid into this. Make the drug mix make a infusion set, drip rate set. Just ask it from the nurses and learn it from the nurses. Now this is a non-invasive ventilator. This is most common brand which all the wards have, ResMed Stella 100. So this machine has CPAP, this has BiPAP. So you will need to know how to manipulate this machine, how to operate this machine. Just type ResMed Stella 100 on YouTube. There are many tutorials on how to use this. So learn how to unlock it, learn how to use it, learn how to set the settings from your seniors. These are important skills what you need to gain, right? So, and then you need to know how to set up, ignore the face, but what you need to know is like where do you connect things like the single limb ventilator tube, how do you connect it to the mask, how to wear the mask on the patient, how to position it on the bed. All these things an HO should be well versed, because they are the ones to lead and they are the ones to advise the nurses on. I'm sure the nurses might know it on their experience, but learn it from them and make sure you are perfect in this. Next, the most important thing is defibrillator. Defibrillator should always be charged. At any time of the day, it should be charged. You should be ready to use it. So the most important thing is, this is the monitoring part where you monitor the patient and then you can give them certain amount of shocks in terms of defibrillation. And you can press this button for synchronized shocks. And some example on this defibrillator even has external pacing also. So in terms of bradyarrhythmias and all, you can try pacing, external transcutaneous pacing from this machine. So these things are very hi-fi stuff, but the basic defibrillating a cardiac arrest an HO should be aware of. So make sure you know where is your defibrillator, is it charged, how to use it, okay? So this is Dextran. You need to be aware of dengue management, how to manage DHF. So next important thing is ordering investigations. Whatever the ward you work, you need to know the forms you need to fill. You need to get acquainted with what is a day lab, what is urgent lab. So you need to know what is the time frames where day lab works, urgent lab works. If you know you sent an investigation, make sure you trace it. If you sent a SC, if you sent a serum electrolytes, make sure you trace it. Because do not be the person to send an investigation and just wait until it comes. No, it's not how it's supposed to be. If you send an investigation, ask the nurses to trace the investigations. Keep an eye on saving resources. Now, when a patient comes for just a mechanical type of shoulder pain, just don't put full LFT, RFT, UFR, ESR. No, just write the relevant investigations, because this is a moment where we are lacking resources, where some hospitals don't even have full blood count. So keep an eye on saving resources. Don't order if it is not needed. So the organization of the medical unit, I told you, there's male and female ward. There's VP clinics, registrar clinics, and SHO clinics. So if you are in a base hospital, you will have only the SHO clinic and the VP clinic. VP clinic will see something called a red number. SHO clinic will see something called a blue number. Now, red visits are something new visits. So usually in base hospitals, the HO has to clock the red numbers and keep until the VP comes. Then when the consultant comes, the HO presents, and then management plan is given by the consultant. The SHO clinics are run by the SHOs, and some HOs also will come and help. That is, they have their routine plan. It's just to check their routine drugs and make sure they get their stuff and their glycemic control, simple stuff. But in teaching hospitals, there's something called registrar clinics. Now, in between VP clinics and SHO clinics, there's something called registrar clinics, where after the VPCs, if there is some critically ill patient, without putting them to SHO clinics, the registrar looks at them. So there will be an HO to accompany the registrar clinic. So example, like when a patient comes with some problems, the HO gathers the problems from the patient, presents it to the registrar, and we decide what to do and we give the management plan. So that happens in teaching hospitals. So in a nutshell, a day in the ward will start like morning, you will go, you'll start your rounds as an HO, and then your SHO will come for rounds, or your registrar would come for your rounds, depending on where you are. And after that, the SR would come for your rounds, and after the SR, your VP will come for your rounds. After the rounds are all over, you will be piled with two piles. One pile is a pile of discharges, one pile is a pile of specials. Now, what do you mean specials? Investigations, referrals, transfers, etc. Make sure you finish the specials first before going into discharges, because that is a must. Clearing discharges. Now, how to clear discharges? There will be patients coming from all sorts of places in your area. Find out the people who live the most far distance. Select them first and write their discharges and clear them first, because there might be issues with buses. There might not be buses towards the end of the day. They might come alone. It might get dark. There might be elephants, like in the eastern province, like in the Uva province, there will be issues with elephants. So clearing discharges according to where they live and timely clearing discharges is very important. The HOs collectively have to get together to clear the discharges. You alone cannot do that. Next, if you are working in a unit which has a daily casualty, you will have to have attending the admissions coming. While you're doing the discharges, when an admission comes, attend the admission and then go back to your discharge. So always have a balance between the admissions and discharges. Some units have afternoon rounds, especially teaching hospitals. They have afternoon rounds where the SR comes and the VP comes and you go through the patients again in the afternoon. And make sure by 4 p.m. you complete all the referrals and make sure you get all the managements done. And then you have the night HO rounds, and then the SHO rounds will accompany that. And then finally, you will be doing the night on call. It might be a casualty day, it might be a non-casualty day. So depending on that, sometimes you might be free, sometimes you'll be busy the whole night. Sometimes even on a non-casualty day, you might be busy the whole night, depending on what sort of patients are in your ward. The next most important, if you're working in peripheries, transfers. There's always an HO for transfers. Even if you are off for the day, sometimes you might be assigned for transfers. So you have to accompany the patient. So when you're accompanying a patient, that patient might be stable, might not be stable. So learn how to intubate, learn how to manage unstable patients, learn how to manage a hypotensive patient. So get that experience. So that's a nutshell of an HO, a day in an HO, working in a medical ward. Then writing discharges. Make sure you have clear handwriting. Make it organized so your unit shines. What I mean by that is your discharge is your unit's identity. Your patient might go and get admitted somewhere else. And if you have given a lame discharge card, that unit will laugh. That unit will laugh at your unit. Like, look at this. I mean, the consultant allows these sort of discharges fly around the country. Like, so make sure your discharges are clear. Write down all the diagnoses, all the working problems. Write down proper history and investigations. Write down the referrals made. If the patient was seen by a consultant neurologist, write seen by neurologist. What plan was given? What is the end of that referral? What has he suggested? And write clear discharge plans. Make sure they have a clear discharge plan and a follow-up plan. Don't strand the patients. The patients sometimes will go clueless. Make sure you explain the patient that this is what you should do. Arrange them follow-up. Write clear prescriptions, because wrong prescriptions can cost a life. There was an instance where a doctor had written mistaken losartan to warfarin, and instead of writing warfarin 5 milligram, he has written warfarin 50 milligram. He has confused the dose. Now just imagine, that's a huge mistake. Thank God the patient has not taken it, but you know, things like that can happen. I know you will be extremely busy, extremely tired, sleepless, sometimes without food, but have that stamina and endurance to write clear discharges no matter what is your physical state. So that is what we learn in our internship. Next is our surgical appointment. Surgical appointment is no different. It's the similar things what I told in the medical ward. So you have your morning rounds, and then you have your SHO or registrar rounds. Then the surgeon comes and does the rounds. And then one HO would have ward duty. One HO would have to run to the theater for theater duty. Then you will have to run surgical clinics also. Clinics are also the same as medical clinics. You have red visits, blue visits, and it's the same. Then the night rounds, on calls, it's basically the same. All wards are same. So medicine and surgery, it's quite similar. I'm sure pediatrics and gynobs have their unique things, which you will be notified soon. So clerking in surgical wards is basically the same. Writing in discharges also the same. Make sure you write clear discharges so that you have your identity, that everyone would say, oh, this is your discharge. I know this is your discharge. You have written this discharge. So make it a point that you get there. So skill development in surgical unit, learn suturing, get enough of experience, jump and go try all the procedures, learn local anesthesia, regional anesthesias, giving ring blocks. Just jump and do all the procedures, or learn all minor procedures and do plenty of it. Assist major surgeries with the surgeons, and make sure you get the experience in holding, the camera of the laparoscope, and like assist major surgeries. That's very important. Write clear op notes. Learn how to write clear op notes. You might need to have a copy of your op notes in your phone initially, but within the due process, you will know what to write. And master and be cautious in post-op monitoring. How to monitor a patient soon after surgery, how to detect that he's bleeding inside, how to detect that this is a bad patient. So how to use early warning score charts. These things should be learned, and it should be mastered as an HO, so that when you are a post-intern, it will be beneficial. Learn to assess wounds. I'm telling you, assessing wounds is a skill. To know that this one, looking at a wound superficially does not make the point. The wound can be infected from underneath. So learn how to assess wounds. That comes with practice. So what is expected from an HO in a nutshell? Accountability. You need to be accountable. Reliability. You need to be reliable. Honesty. If you did not check the blood pressure, do not fake it. Always make sure you be honest in what you do. Knowledge in basic emergencies. Must master it. It is expected from an HO. Always call for help. Don't be overconfident that you try to manage everything alone. Call for help. Call your seniors. And always be energetic. Like, don't be hypothyroid. Just be energetic to do and handle all the work. And coming to internship is a huge achievement. It is your start of career, and I'm sure you will love it. You will enjoy each and every day. Just love what you do. Be passionate about what you do. And all what I have to say is welcome aboard and congratulations. So now I'll just hand over to Dr. Sumaiya, so that she will brief you on how things happen in a GYNUBS ward.
You have shared the screen, right? Hello, guys. I'm Dr. Sumaiya. I'm actually an MO, but working to all the units in Indore, but I'm more interested in GYNUBS. So I'll give you all a brief introduction on what, as an GYNUBS HO, what are the things you might do. Actually, when it comes to medicine, especially GYNUBS, especially obstetrics, mostly you'll deal with not patients, you deal with mothers. So you should be always extra cautious. And the other thing is like, it's a very huge thing. Like if something, the only ward where you'll never see maternal, you'll never see deaths, not like the medical or the surgical ward. Even in pediatric ward, you could see, but in a GYNUBS ward, it will be one of the rarest condition. Maybe like in my history, like I have started to work for 4 years. In this 4 years of duration, I have not seen a death in GYNUBS wards. So you should be extra cautious, because if such deaths happens, it's going to be a huge inquiry. As Sri Lanka has a good statistics in maternal side, and there are very less deaths and everything. We are like even above US and UK and all those things. So the inquiry is like very difficult. As you are an HO, you can't escape. You are also responsible for it. So that is the first thing I would like to highlight. And the other thing you should know is you're dealing with a mother and a baby, 2 lives, not like other units. So you should be very extra cautious. And yeah. So as a Gynae Obs unit, we will have 5 categories to work. It will be the antenatal clinic plus the wards, then the postnatal wards, mostly the postnatal ward when the patient gets discharged. If they have to be reviewed, they'll be reviewed in the antenatal clinic mostly, or the gynecological clinic. Then will be the labor room, and then the gynecology ward and the clinic, and then the theater. These are the places where you will be working. Then I would first go for the antenatal clinic. I'll just give a brief idea. I'm not going to teach you all how to calculate the EDD or POA and all those things. I know basically you all know all of those things. The basic important thing when it comes, I'm sorry that I do not have a picture of the antenatal card. I couldn't find one. Actually, when it comes to the antenatal card, I think most of you all would have seen. The first page will be always filled by the visiting midwife, the field midwife, like each when there is a person, that means what the field midwife does is, like if there is a person who has just got married, willing to get pregnant, they'll be followed by them. And after pregnancy also, they'll be followed by them. And once they are confirmed as pregnancy, they will be given a card. It is the pregnancy record. Okay, in that pregnancy record, the most important thing is the blood group will be highlighted, and at the first page there will be the highlighting of blood group, past medical, surgical, and any allergies or anything, and a brief history like the patient's name and the personal details. And then in the side, there will be a chart where they have mentioned the last menstrual period and EDD calculated according to the last menstrual period. And then there will be a corrected date. Corrected date is usually the most accurate one is with the ultrasound scan. So after the ultrasound scan, they correct it and they will be jot down. That also will be jot out, and the gravity, para, and the live births, like that also will be highlighted in the first page. Then the second page also will be filled mostly by the midwife, where it is the personal details of them, what profession they are in, what their husband's profession, and their previous deliveries, and like where they delivered, which station they delivered, what are the birth weights, and what boy or girl, what is the age, and all of those things. Then this side, there will be a part where it is given to the MOH people. That is like the hospital people as HOs. We have maybe in your post intern you all have to do it, but as an intern it's not important for you all. They will deal with it. And then the other side, there will be a part for the antenatal hospital clinic. That is the most important thing when patients comes to our clinic. We usually used to do, but what are you supposed to do is monitoring blood pressure is a very important thing. And basically you should see what are the investigations, and you should take a short history and all of those things. And then ultrasound scans mostly, which will be done by the SHOs or VOJs. In complicated cases, it will be done by VOJs. As in teaching hospitals, it might be done by registrars and stars. Okay, then finally there will be a part, just a note, like if we need any relevant note, like any referrals and all of those things, yes, we could write in that. Or every visit, if we have any special notes, we could write. And the other part will be after delivery, whether it's a normal delivery or cesarean section, whether episiotomy was put or what, like made or whatever it is, whether was it sutured, and all of those things will be written in it. And the details of the baby. Okay, then afterwards, the discharge of the baby, that will be discussed by Dr. Kaushini. Then what would happen is, first, after calculating the EDD, POA, and everything, the most important thing is you should take a brief history. For example, like if she has any past medical history, especially if she's an epileptic, chronic diabetic, chronic hypertensive, or a patient with any heart disease, because there can be situations where this patient could continue the pregnancy, or we should go for a termination of pregnancies. So we should always, in the booking visit, we should always take a good history and identify whether this person is a person who could continue these pregnancies. And then histories of miscarriages and all of those are very important, because, you know, like when it comes to getting pregnant, like there are a lot of problems in this world now lately. Those days it was not a huge thing, but now, like, you know, every third pregnancy of a person is a miscarriage. So there will be some people coming with even 3 miscarriages, still not conceived, not having children, and age also matters. So like maybe 38, 40 years, this pregnancy must be a diamond for her. So you should always make sure that you are taking a proper history to not fail it. Okay. Then afterwards, you should always do a proper examination, such as cardiovascular examination. I know maybe for an HO, it is not that this thing that you might be able to identify a murmur. It's okay if you are not able to identify a murmur, but just auscultate and see. You could differentiate the normal and abnormal, right? So, okay, you feel it's abnormal, then you can refer to the seniors, and then seniors could go into this thing, because in pregnancies, maybe previously they were having some issues like maybe some valve problems and all those things, but they'll be always highlighted in pregnancies. Okay, like it will be exaggerated because a women's physiology completely changes in pregnancy because of it. And then the any respiratory thing, pathologies, and always see for her mental, as changes of hormone, there can be mental unstable mentality and all of those things. So you should always see for that, and make sure that there are like some drugs, particular drugs before pregnancy she would have taken, but that cannot be continued in pregnancies. So make sure that you should refer to this VOG, and VOG will do a referral to the specialist, like relevant specialist. For example, a neurologist, if it is an epilepsy patient who is on sodium valproate, you know it is contraindicated in pregnancy. So to change the sodium valproate, we can't just go and change it. We should give a referral to the neurologist, and the neurologist will decide. So it's usually like that. So you should identify all of those problems, and always go for a breast examination. And then when it comes to ordering investigation, the most, 1 minute. Yeah, we will give you guys the recording. Okay, no worries. We will upload it in our this thing. Yeah, we will upload it. Yeah. So it's like that. And as investigation, when it comes, it's the 2 most important part in that means important time that you should take the investigation. One is the booking visit, and the other one is the 28 weeks of POA. Booking visit, you should make sure always to take a full blood count, especially to see the HB. As you know, when it pregnancies, there is dilutions, and because of it, there can be low HB. So to maintain that, you should always make sure about the HB, and there can be pregnancy-induced thrombocytopenias. Because of it, you should see always for the platelets, okay? And then you can go for a PPBS, that is postprandial blood sugar, 2 hours, mostly it's 2 hours after having a meal. And in some conditions such as if it is an elderly pregnant mother, maybe we would go for an OGTT, that is more accurate, like, okay? OGTT is a glucose tolerance test. You will just have you will just know how, have a review, like you'll just try to learn how to do it, like how much of glucose is given, and after whichever you used to, like it's usually after, first we used to see for the fasting, then we give a glucose, and then after 1 hour, then after 2 hours. That's how we used to take, and the range and all, you all should have an idea. Then only you all can find that this is abnormal and this is normal. It will be that. Then we do an UFR to see any infections, because women are prone for infection, you know that, and pregnancy, as the immunity goes down, they are more prone for infection. And the other thing is, in other countries, they do like VDRL, HIV, Hep B and all, but in Sri Lanka, we don't do, because it's very rare, Hep B and HIV, but we do VDRL, okay? And then the next thing is blood group. Blood group is one of the important thing, because we can't miss that, because there can be rhesus negative mothers. That is actually a huge problem. Maybe they might have any sensitizing event during pregnancy, and we have to give rogam and all those stuffs. Then later on, even after delivery, we should check for the baby's blood group and go for rogam and all of those things. And antibody screening is one of the most important thing during pregnancy in a rhesus negative mother. Usually don't ever miss it. In the booking visit, you should send for antibody screening. Then again at POA 28 weeks and near to the delivery around 36 weeks, you should give. Okay, then I have given another chart after this. Briefly, I have wrote everything, what are the investigations and the scans and all things. The scans, the most importantly is, it's like this. In the first visit, if the patient comes around 10 to 12 weeks, yeah, you can do a dating scan. But just imagine if she comes early at 6 weeks, once she's just diagnosed pregnancy, yeah, she's coming. Once her urine HCG is positive, she's coming to you. Then, yeah, you can't like, the dating scan would not be that appropriate. So what you should do is, you should review her at 12 weeks to do a dating scan. And then at next scan could be at 20 weeks. 20 weeks is a very important scan where we detect all the anomalies in a baby. Okay. And then at 28 weeks, we used to do a scan to detect the early IUGRs, see for the growth of the baby, and we can detect early IUGR. And later, again at 36 weeks, we used to do the scans to detect the IUGR as well as placental locations and mode of deliveries, maybe sometimes the presentation and everything. If the baby is a breech, yeah, we will review her at 38 weeks again, we'll go for a scan, and still if the baby has not come to cephalic, we would go for a cesarean section. So this is how it goes for a normal pregnancy. But some other complicated pregnancies, yes, we would even do scans every month, maybe once in 2 weeks. Whenever it's relevant, we will do. So these are the basic idea I have given you in this chart. You can have you can read it. And then I would go for the antenatal ward. When it comes to antenatal ward, first, most of the time, the admissions will be patients with above 28 weeks of POA, where they will be needing CTG monitoring and all of those things. So they'll be admitted. Okay. The first thing, there will be patients who are admitted for labor with labor pain, and they'll be like reviewed and sent to the labor room for the delivery. Second, there will be patients with maybe post date or due date without pain, where we would have admitted for induction of labor. Mostly induction of labor is of 2 prostaglandin. Yes, we can do a vaginal examination and we can do ASM. Or either some consultants mostly, because ASM will not work like when it comes to primary mothers and all. Multi, yeah, it might, but primary it might not. So mostly we used to go for prostaglandins or Foley catheter insertion. When it comes to prostaglandin or Foley catheter insertion, mostly HOs are the one who performs that. So just know the procedure. It's not a big deal. You can just YouTube it and know how to insert a Foley catheter as induction of labor. Okay. And then that will be the admission. Then again, there will be patients for BP monitoring. Maybe sometimes they might be chronic hypertensives, or they might be pregnancy-induced hypertensions. So if the patient's BP is above 140/90, which you saw in the clinic, or either the MOH people would have seen, or either the midwife at the home visit would have seen and sent you the patient. So you must know what to do in a PIH mother. Like the things is, you must know what are the PET symptoms, whether she has PET symptoms, and the examinations, and what are the investigations you're supposed to do. I will brief it in later on for you. And then there will be patients for BSS monitoring, maybe chronic diabetic or GDM, who are on oral hypoglycemic, who are on diet control or insulin. So you should make sure that those patients, or some patients with some medical problems, pregnant mothers also will be coming to ANC ward if they are above 28 weeks, and we will do our relevant thing and we will refer for the relevant consultant for further management. These are the 3. This thing. And the other thing is, when you are clerking, you should always make sure to mention the blood group in the BHT, if it is negative or positive, and what sort of the blood group. Then always mention her parity, gravida, and live births. And then always mention the LRNP, EDD, and calculate the POA. And in the side, always write it as a small note. If it is past LSCS, okay, like how many LSCS she has gone. And after that, if was there any complication, maybe there would have been maternal complications in past pregnancies. There would have been neonatal complications in past pregnancies. For example, there would have been neonatal deaths due to GBS and all of those things. So in pregnancy, prior from first itself, we have to give prophylactically antibiotics. So make sure you take a proper history of her past pregnancies and everything, and have a small jot down in the end of the BHD. And then later on, the core complaints, why did she come? Maybe she's a requested admission by the VOG for BSS, or maybe she's a requested admission, always mention that. And then her complaints. And as she is above 28 weeks, make sure her fetal movements are appropriate. If it is not, you should always consider it, especially in complicated pregnancies. Reducing fetal movement, we should be always very careful. And then afterwards, she asks always for her bowel habits and urine output, because bowel habit is a very important thing. Some mothers really suffer with constipation in pregnancies because of the gravid uterus. So make sure, like, make that pregnancy very comfortable for them. So make sure that, and then go for the past surgical histories. And because there might be some abdominal surgeries which the mother has gone through, because of that she can't be going into the normal delivery. Sometimes she would have had hemorrhoidectomies and severe hemorrhoids now. Because of it, no, she can't go through. So we should always have a proper surgical history. Maybe she would have gone through a spine surgery. So much of issues are there. So you should always make through of that. And then make sure of the allergic history, because you're dealing with the mother and the baby, 2 lives, I already told you. So make sure of the allergic history. And then the past obstetric history. Okay, what is this? Is she a primary? Is she a multi? And how was the past delivery? Was it a cesarean? If it is a cesarean, ask for the indications. And what's the age of the baby? That's a very important thing, because, like, you know, at least in each pregnancy we should have a 2 year of gap, because like once the uterus to come back, at least we need to give 2 years and come back to the normal anatomy and physiology. We should give at least 2 years gap. So because of it, we should make sure, like, you know, sometimes they will be coming with 6 months, baby 6 months and pregnant, and 1 year and pregnant. That means when baby was 6 months, they would have conceived another baby. So in situations like that, we should always be extra cautious. Because of it, we should always have a good history. And then in the examination, you will do the basic examination such as blood pressure and all of those things. And always don't forget to auscultate the lungs and the heart again for any murmurs, because later in pregnancies, the murmurs can be exaggerated than in earlier time. So you will be the first one to detect that sometimes. Some people would have missed it already. So always make sure that. And then abdominal examination is one of the important factor. Yeah, if a patient comes in pain, she might have come with labor pain, but with a history of past surgical, you should always see for scar tenderness, always palpate the abdomen for any tenderness. There can be the patients presenting with antepartum hemorrhage with a tender abdomen. So don't ever miss that. That is a critical emergency. When it comes to placental abruption and all, like sometimes it can't even detect it in ultrasound, but maybe while examinations and your CT investigations, yes, you should go for an emergency section. So always measure for it. And symphysis of fundal height, don't ever forget to measure, because you can detect IUGRs in early stages. And you can, because when it comes to when we just keep with IUGR, some patients with scans we could, but be the first one for you to be you as first one to detect all of those problems, because like you can really impress your boss at that time. And afterwards, vaginal examination, make sure always there can be P-proms and proms presenting to your ward. So make sure not just go in above 28 weeks and all, like maybe like within 28 to 32 weeks of period. Just don't go at one stand for a vaginal examination. You better go for a speculum examination, because vaginal examination also can induce more infections. Because of it, you can go for a speculum examination. And yeah, put a speculum. Mostly we use Costco speculums, and I will show you what's Costco and all of those later, and what would you see in that. Okay, then make sure that she's not dribbling. She's not dribbling. And if she is dribbling, make sure it is not meconium. Meconium is, it will be greenish in color in different consistency. It's like mild, moderate, and severe. You can like, that is a complication. You should go for an emergency section. You can't deliver normal. If it is thin, yeah, you could try a bit. But in some case, when the CTG is also this thing, because highly prone to affect the neonate, because of it, we have to go for an emergency section at times. So make sure of vaginal examination. When you do the vaginal examination, see for the os, how much it's dilated, see for the effacement, what's percentage of effacement, and then see for the station and see whether the membrane is plus, and if membrane is not plus, see what is the color of the meconium and those things. Okay. And when you do an vaginal examination, first just have an external appearance. Is there any whitish discharge? Is there any fluids? Or is there any other infections like? So always make sure about it. Okay. And then when it comes to PIH mother, extra examination would be always check for the knee jerks. It will be always exaggerated, and we can like say it's preeclampsia, eclampsia, all of those things. So you just know what are the symptoms you should ask. What are the PET symptoms you should ask in a pregnant mother with high BP, as well as when it comes to pregnancy with high BP, always make sure to test urine albumin. It is one of the important thing. It can like differentiate whether the patient is going into eclampsia or preeclampsia. The preeclampsia, the diagnosis itself, urine albumin should be positive. Okay, and afterwards, when it comes to monitoring is of two parts in the ward. Make sure the CTG is done, and FHS, that's the fetal heart sound, at least thrice a day when the patient is admitted at the ward. And if it is a complicated pregnancy, maybe you all have to make it more closer monitoring, maybe 4 hourly, maybe 6 hourly. Yeah, so it's like that. So make sure that you do ask for the relevant symptoms and relevant signs, as well as relevant investigations are sent. Usually in patient presenting with PIH, we used to see for the clotting profiles as well, and the LFTs and RFTs, because the preeclampsia patients can go into HELP syndrome. Because of it, we should always monitor the LFTs as well. So make sure of that. And the GDM mothers, yeah, I have already told. The BSS is usually blood sugar series. How we do that is there will be fasting and postprandial blood sugars, such as post breakfast, post lunch, and post dinner. At least for 24 hours we would have monitored, and it depends upon the consultant. Some consultants monitor just after 1 hour, some monitor after 2 hours. So know the trend of your consultant when you go to your station. That will be helpful. And afterwards, that's it in this thing. And the other most important thing is, when an admission comes, make sure, especially for an elective cesarean section, if a patient comes, make sure a blood group and DT is sent, because when it comes to cesarean sections, like it is a must. You should have it. You should have a blue chit ticked in it in your BHD. Make sure that it is there. And in prostaglandin inserted patients also, it's a must, because they can go into uterine hyperstimulation. Because of it, they can go into fetal distress, and they can go into emergency cesarean section from the ANC ward itself. So end of the day, you can't dance here and there. So better you be prepared for everything. And then just after prostaglandin insertion and all, the CTG should be monitored 1 hourly after. And then when relevant, but that depends upon some consultants, they used to do 4 hourly as well. And vaginal examination is also same. Each time it's like it's not healthy to do vaginal examination on and off. If there is a real indication, yes, you can go. If there is pain and all, yes, you can do. But when you do an vaginal examination, make sure it is proper. And if it is like, if she's in the first stage of labor, yeah, you can send the patient. And make sure that before you send, if it is like possible to give the enema and send. If not, yes, you will have a hard time in the labor room. Okay. Then afterwards, yeah, this is above the antenatal ward. Then we would go for the day in, how our antenatal ward runs an HO's life. Okay, like in the morning, yeah, there will be an HO round that should be, of course, done before 8 a.m. in most of the wards, even sometimes by 7 and everything, because you should do your vaginal examination. The relevant patients should be sent to the labor room. The relevant patient should be prepared to the theater, because the theater will be starting like around 7:30 sometimes in some hospitals. So you, before that, you should complete your rounds. And if it is a tertiary care, there will be registrar round. But if it is a base hospital or DGH, yeah, an SHO round, then a VOG round. By the time a VOG comes, you have to have even done the vaginal examinations. You have to read your CTGs and everything, and make sure if the CTG is supposed to be repeated. And another thing, you know, like mostly the ultrasound scans, SHOs and consultants do. But if you want to really learn, you can do it when you have a free time. Just take the patient just on the scan machine. You know, how we learned is like, first we just learned how to detect the fetal heartbeat. Then only the biometries we learned. So likewise, you all can learn. It's not an hard thing. Everyone can learn. It's all skills. By skills only you will get it. By practicing only you will get it. To learn the skill, you should practice. And the other thing is the new admissions. I told you how to clerk. And then specials such as sometimes the patient would have come for blood transfusion, sometimes some referrals, and sometimes some investigations. You should fill all those things. And in an ANC ward, like medical ward and all, we do not do much investigation. Mostly the only investigation would be sometimes a full blood count. Okay, as we are working in government hospitals, we should be always considerate about it, because there are limited amounts of samples, limited amounts of reagents. So we should always be, we can't just unnecessarily order investigation. So we should be always very clear about it. Then sending the patients to the labor room. And we do not have any evening rounds or afternoon rounds. Maybe if it is a tertiary care, maybe they might, but mostly a night rounds by the HO. And sometimes an SHO would do a night round, but sometimes all depends upon you. So do a proper round in the night if you are tired, even, because you must not miss any case. Okay, maybe the CTGs and everything should be read very clearly, maybe because there can be IUDs later on, and there can be issues afterwards. Don't ever think that just because you are an HO, you are not responsible. Not like any other ward. In Gynae wards, yes, you are responsible. You'll have inquiries. And I know in my batch there has been people who repeated their whole appointment just because of missing some IUDs and missing some APH, we are leading into deaths and all of those things. So always make sure you don't miss all of those things. You have much responsibilities than any other ward. Okay, now we'll go to the labor room. It's the next part after the patient comes to the ANC. The next part is the labor room. In labor room, the main thing is you should know what is the indication, whether the patient is in labor to send. You can't just send a patient with 2 centimeter, not much of that pain, not much of contraction, and the patient at last will end up in lack of progress and in a cesarean section. So it will be a huge black mark for you. So make sure that the patient is in labor before sending to the labor room. And then know all the stages of labor: stage 1, stage 2, stage 3. We are 4 centimeter to 10 centimeter dilatation in stage 1, 10 centimeter to the liver of the baby is stage 2, and stage 3 is placental delivery. So make sure all those are managed, and how all of those are managed, and what are your responsibility, what are your responsibility in all of those stages. And always don't be hesitant to call for seniors help. In case when you work in a base hospital, maybe you'll call your SHO, but he's not responding. Don't worry, call your VOG. I know, like my baby, some person will scold, some person will be very friendly, but it's very less that VOGs are being very unfriendly. They are always friendly. Anytime you call, you will come, because when I worked, my VOG was very nice with me. He was very nice. He was very friendly. I'm not scared to call him at any time. If I can even bypass and go and ask sir for opinion, bypass the SHO and ask sir for an opinion. So it depends upon the consultant you work with, and then you'll have to deal with instrumental deliveries, forceps and vacuum deliveries. Mostly we do not do that. Maybe either the SHO or the VOG who will be doing HOs. It's very rarely, but someone, if they feel that you are confident enough to do, they might give you. And then identifying emergencies. CTG is a special monitoring in the labor room. Always see for fetal distress in any conditions. And then when it comes to just after you put the patient in the labor room, you have to do a vaginal examination again, and you have to do an artificial rupture of membrane to induce the labor. So make sure that when you do the artificial rupture of the membrane, make sure the color of the lico, whether it's a bloody color or whether it's meconium or whatever it is. And then maintaining partograms. I'll tell you about partograms. Yeah, it's mostly usually maintained by the midwives, but don't forget to see, because some point it might not have been maintained. Okay, so you have to always see. Then suturing, episiotomies and tears. Episiotomy, yeah, first when you go, it is really a difficult skill to learn, because as foreign graduates, we had very less experience in it. Don't worry, sometimes your midwives are very helpful. When you are very friendly with them, they will teach you. Even no need to ask for your seniors. If you just tell them, they'll help you. And within another 2 or 3 episiotomies, you'll be like really you'll know it, so nothing to worry about it. Then tears. Okay, perianal tears, there are different degrees, like first degree, second degree, third degree, and fourth degree. When it goes above third degree, you should always know to identify it. When it goes above third degree, you can't do it. You should always ask for the senior's help. And sometimes it might even need the help of the surgeon. Okay, then monitoring after the delivery. After the delivery, yeah, the baby is also monitored, the mother is also monitored, but basically the mother is monitored more, because there can be chances of postpartum hemorrhages. So usually in the labor room, patient will be monitored for 2 hours. Okay, so this is in this picture, you will know, like I have given you all the cervical dilatation and all those things. Just have an idea with this picture, like how much of dilatation. Different people's finger changes differently. So just have an idea, like you can keep your finger and have a measurement. Okay, this is 1 centimeter, this is 2 centimeter. Like how many fingers you could like stretch it this way. You could see, you can go this way when you do the VE, then you could see like how long it is. And then while doing a vaginal examination, as I told earlier, yeah, you should see for the dilatation, effacement, the station, membrane, and the like color, and as well as caput and molding. And you should know to grade it always, because if it goes to the highest grading, it can cause damage to the fetal brain. Because of it, we should go for emergency sections. And then this is the picture of the episiotomy. Episiotomy, yes, it could be mediolateral as well, midline episiotomy. We do not practice midline now, because it leads to a lot of anal tear. Because of it, we go for mediolateral episiotomy. And after the 3rd pregnancy, some patients will not even need an episiotomy, they would have delivered. So you should master how to suture it. Usually how we suture it is, we suture the vaginal mucosa first, and then we go for the muscle layer, and then only we suture the skin. So we have to put 3 layers of suturing. So you have to do that. Okay. And then this is a picture of the anal tear. Just have an idea of it. I don't want to explain, because I have to go much into the sphincters and the anatomies of the anus and the rectum. It will take a lot of time. Because of it, you just have an idea what is the 1st degree, what is the 2nd degree, 3rd degree, and 4th degree, and know how to identify it and when you need the help. Then there can be cervical tears as well. So when it comes to cervical tears, it's very difficult, because you can't give local to the cervix. It's very difficult, and suturing is very difficult. Still, if you feel difficult, yes, you can ask for your senior's help. And this is the partogram. Partogram has 3 parts. Actually, the personal informations of the patient, and then the fetal monitoring, and then the maternal monitoring. Now this action line, alert line is out of the guideline. No need to worry about it, because that I know that when you are a medical student itself, it was a huge headache. Now that headache is gone. But you should make sure that you have fetal heart rate monitoring, CTG monitoring, amniotic fluid, whether it is meconium clear, those should be molding, and all of those things, and the contractions. Okay, and other things, the drugs used. Okay, and then the maternal monitoring such as pulse and heart rate and all of those things, BP and heart rate and all of those things. And the other thing is augmentation of labor. Usually we give syntocinon in the labor room. It depends upon the multi and the primary. Okay, 15 drops per minute light it usually used to go. If it is a multi, we used to start with syntocinon 5-unit infusion. If it is a primary, we use if it is a primary, we used to start 5-unit. If it is a multi, we'll go for 2-unit. And it depends upon, when you see the CTG, you can see the intervals of the contractions, right? And in the partogram also, you can see the intervals of contraction. Depending upon it, you can increase or decrease the syntocinon infusion. That is before labor, to augment the labor. Then after that, as prophylactically to prevent postpartum hemorrhage, we used to give in the labor room syntocinon, usually 30. Some patients, some we give 20, some we give 30, some we give 40 unit as an infusion. Okay, yeah, those are the things about the labor room. And then the postnatal ward. I would talk about the postnatal ward. Postnatal ward is a common ward. Most of the people miss it, especially PPH, and then post-delivery PIH and GDM monitoring and management. Always we just don't consider it. We just come, we just do, sometimes some HOs don't even want to monitor the BP. When you are HO, you should go take your blood pressure meter. Each and every patient, you should monitor your BP. You can't just, and you should see your pulse and everything and write. You can't just write what it is in the monitor. Okay, it is actually every HO's responsibility. How busy it's, how much of patient you have, it's not a problem. You should always do it. And postnatal ward, don't ever miss to do that. And just don't think that she's not a PIH in her pregnancy because of it. Okay, I'll just write the BP. No, maybe after delivery she would have got high BPs, or after delivery she would have been bleeding and she's going into PPH. So BP, and always touch the pulse, see whether it's low volume, whether the volume is good. Always you should make sure about it, so you can prevent patient going into severe PPH. Before that itself, when mildly, you can treat and stabilize the patient. Okay, so when it comes to PPH, it's one of the important thing, especially on your theater days. After many cesarean sections, many patients can go into PPH, or multis and grand multis are very prone for PPH. So always make sure for that, like you monitor the patient properly. And then afterwards, detecting the emergencies and all of those things. Eclamptic patient, there can be post-delivery eclampsia, so make sure you monitor that. And diabetic and PIH mothers, make sure on delivery you have a proper follow-up plan, that they are not missed. Sometimes, the PIH patients, they would not have been told to monitor the BP. They would not have given any antihypertensions. They would come with eclamptic episodes. Recently, something like that have even happened in the area where I am working. Patient presented with eclampsia. So make sure that you always have a proper follow-up plan. And then when it comes to gynecological ward, it is nothing much. If it is obs patients in gynecological wards, they'll be above 28 weeks, mostly miscarriages, ectopic pregnancies, and gestational trophoblastic disease. So when it comes to miscarriages, yeah, misoprostol, you should know the doses of misoprostol and how they are inserted. Ectopic, yeah, it sometimes there can be patients who we are managing medically, and then surgical managements. But medical managements and patients will be on monitoring. So make sure that you have done a proper history and proper examination to avoid that means to just detect whether the patient needs a surgical evacuation quickly, earlier. Okay. And then gestational trophoblastic, always keep an eye on your urine HCG and beta HCG. Yeah, beta HCG. Then other thing is, you should make sure about your hyperemesis gravidarum patients. Make sure always they have an input-output chart to see the fluids, enough of fluids, whether the enough of fluids being given, and how about the urine output to be monitored. Then always see for urine ketone bodies. That is a criteria to diagnose hyperemesis. And maybe like there can be some patients with excessive vomiting but not hyperemesis, and they can, because of excessive vomiting, they can go into hypokalemia and hyponatremia and all of those things. So make sure to monitor the serum electrolytes. And then there can be gynecological surgeries, patients admitted for TAH, VHNRs, anterior posterior repairs, or some ovary cystectomies, or any other gynecological pathology, maybe the ovary, tube, or the uterus, or the cervical pathologies. So make sure you take the consent before the surgery, and make sure the patient is prepared for the surgery pre-op, especially catheterization, because many of the units, many of the nurses misses that. So HO, it's a responsibility, because after taking to the theater bed, we can't be doing catheterization. Because of it, make sure of it. And then post-surgical management, make sure that you know all the post-surgical management in case like if she needs blood transfusion and all of those things, that should be done. And afterwards, then you should know about prescribing in pregnancies, to handle emergencies in labor rooms and ANC ward and all of those things. And then when it comes to the theater, always know how to write the op note. I can't tell for everything because different surgeries will have different op notes. When you go, you just take, if it is a TH, maybe your previous batch would have done a TH 2 days before. She would have been admitted at the ward still. So just have a look at it and just take a picture. For first year, you won't be remember to write everything. Just you can see the picture and adjust the op note. So just make sure about it, and monitoring and all of those things. And when you're working in the theater, when you're writing the op note, make sure to highlight the relevant things. Maybe sometimes this patient needs extra monitoring. Maybe this patient has suspected internal bleeding, maybe so is suspecting. So yeah, you should monitor this patient very closely. Make sure to put a note about it, and you should make this patient extra to keep the patient extra nil by mouth. Then yeah, make sure that this thing, and the days of antibiotics more than 24 hours, always make sure that that's properly written. And then blood transfusion, I want to talk about it. I thought Dr. Ishfak would talk about it. I think he missed it, but it's okay. I'll talk. It's like this. A blood transfusion is a huge responsibility, and it can just take you out of your career. There has been many incidents like that. So when you transfuse blood, make sure that you're transfusing the correct patient, because sometimes the patient's bed would have changed. You would have thought, okay, this is a second bed patient, I'm going to transfuse, and you might go and transfuse the wrong blood to a wrong patient. Don't do that. Always make sure about it. So always check the front admission sheet with your blue chit, and make sure that it is the same person, and then check your blood pack with the blue chit and make sure it is the same person. Then go with your BHT and go to the patient, ask what is her name, make sure her name is correct, ask her home address to reconfirm it, make sure that she is the patient. Maybe there might be a bystander's number, a guardian's name. You can even ask that and make sure that this is the patient. And then make sure that you always start the blood transfusion, because it is because you are the sole responsibility of it. You can't just give to a nursing officer or someone else like that and go. Because in the BHT, you are the responsible. You are the person who is starting the transfusion. Then you are the one who is who is responsible for it. So later on, when any problem happens, you can't say that nursing officer started or someone else started. You can't just tell like that. You will have to take the responsible. So to make no problems, in your life, as while transfusing blood, what you do is you make sure that you start the blood transfusion to that patient. And then I would just go and rough this thing on instruments. This is the Casco speculum. This is the SIM speculum. Casco is usually used mostly in obstetric wards and all. SIMs usually we use when we have these vaginal procedures, such as to do a DNC, VHNR and all those things. We use Casco SIMs. But casco is usually a frequently used. Yes, when you insert a casco, make sure this handle doesn't go towards your anal side. It can cause anal damages. So make sure it goes up towards your bladder. That means towards your mons pubis. And then when you review it, yeah, this will be the inner finding. It will be your cervix. Always make sure to write whether the cervix is healthy or what sort of all the findings you find. External findings, then the internal cervix findings, and any discharges or anything. Make sure you write all of those things. And then vacuum deliveries. Vacuum, usually it's kiwi, which we use now. There is a normal cup, this thing also, that the suction cup, we usually doesn't use that nowadays. It's out of practice now. So kiwi is the one which we use when you go to your labor room. Yeah, you can ask for a kiwi, and you can see the videos like how I mostly learned all these vacuum deliveries and all small videos from YouTube. Okay. Then these are the forceps. It's very rare now we use forceps, and if it is only a VOG who's very competent will use forceps. Yeah, because it's very out of practice now. And then these are the instruments. Okay, in instruments wise, you should know, not needed really to do. You can know the needle forceps. Sponge forceps is one of the important thing. Then towel forceps and all of those things. Yeah, then after that, this cannula, this HST cannula is an important thing when you go, especially when you do lap and die in patients. We used to see for any tubal block, or either we do for hysterosalpingogram. During that period, you should insert this inside the cervix, dilate the cervix, insert inside the cervix, and then you inject the dye. Okay, and yeah, then this is the valsalum. When you do any procedures, vaginally, you have to, if you have to hold the cervix, yeah, we used to hold the cervix with the valsalum. And this is the uterine sound, where you use it to see the uterine cavity and whether it's anteverted or in the position of the uterus and all of those things. These are the dilators. You have to first dilate the cervix, then insert the uterine cavity, and then only you should do your further procedures. And then if we are doing DNC, dilatation and curettage, this is the curating things. You can curate with these. Okay. And then when you go for a cesarean section, yeah, this is a scalpel and blade. And then when you go for a cesarean section or major sections, yes, retractors. You should know all of the retractors. In that, most important things which use it's Madison retractor. And afterwards, the suture materials, the absorbable ones and non-absorbable one. Mostly episiotomies, the vaginal mucosa and the muscles, we used to put absorbable. Even the skin used to put absorbable in some condition. If it is too big, if it needs a non-absorbable, yes, we can go for non-absorbable. Likewise, only in surgeries as well. In midline and all, mostly we go for non-absorbable surgeries. So you just know the suture materials, and then these types of needles, they are very important. Round body, curved, cutting, and all of those are very important. Which place which could be used, that's a very for example, when you suture the vaginal mucosa and the muscles, we mostly use a round body. But when it comes to skin, it's very difficult because skin is very thick, right? So we used to use the cutting. So make sure that you know the types of of these things. Yeah, that's it about gynae. If you all have any doubt, yes, you all can ask. And thank you so much for listening. And yeah, I would give to Dr. Kaushini.
Hi. Hello, am I audible?
Yes, you are audible. Wait, let me just stop sharing my side so that you can share it from your end. Right, I've stopped sharing it.
Okay. There's a bit of a background prayer. Is it bothering?
No, it's okay.
All right, right, okay. So I will start sharing my screen. Why is the delay?
Is it sharing, Kaushini?
Giving me a about me. I'm working at BHN in the board. I finished my internship somewhere in 2019-20, that range. That was the year. And I'm just going to share my experience with you about the pediatric appointment. Right. I think there are some participants who may want to just answer like one question or two, right? Otherwise you guys will fall asleep. I just have a very short PowerPoint. If you all can just answer some of the questions, I'm not going to ask any theory, don't worry. So why do you guys think this pediatric appointment is any different from the other appointments? Can someone unmute and just answer? Why is it different? Like, you're handling babies, obviously. So how do you think it's going to differ from the rest of the appointments?
If
No
if you're shy to talk, you can even type it in the chat box. No harm.
Hello? Wow, nobody can unmute. Y'all are going to be interns very soon. I'm sure you join to get some idea about this internship, right? So just give me like one answer. Because they can't talk, it's tough. Yes, that's right. That is actually one answer. And they are uncooperative at times, right? So I'll just move on with the next slide. Like their diagnoses are entirely different, right? Sometimes it's not as straightforward sometimes as the adult diagnosis. Like, do you think you are going to ever see a febrile fit patient in a medical ward? No, right? Highly unlikely. That typical febrile fit, so that doesn't occur after 5 years of age. And you guys have to go on TDS rounds, that is thrice daily rounds. So that is one difference that you have to remember. The normal values are different, right? Blood pressure values, pulse rate values, their respiratory rates, everything is different. And sometimes sensitive, uncooperative patients, right? And patients, most of the time, patients don't give you the proper history because they're babies, they cannot articulate, or they are too sick to talk, they're just too moody to talk, too many reasons. And so you'll have to take the history from the bystanders who may not be reliable most of the time, or like, half the time. Sometimes the child may be brought in by the grandmother. Then the bystander who stays with the child could be the mother, rest of the state. So that history may differ. Or like the patients, unlike adult patients, they rapidly deteriorate or rapidly progress, which is a good thing, right? So these things are very different. And also coming to the legal aspects, there seems to be some legal concerns in these wards, right? You like more than the medical wards, like adult wards. You have to think about that aspect as well. And in your internship, you will have to cover up these areas like the pediatric wards and ICU wards, then the premature baby unit or the special care baby unit. You will have an appointment there, either in a rotation or like say 2 months straight in the BPO or something like that. Depends on the consultant's wish. And then you will have your PHO duties, that is pediatric HO duties, mainly attending to emergency or like elective sections, normal deliveries, labor, right? And some consultants may want you to work in postnatal wards, taking care of the postnatal, like the babies, right? Newborn babies. And then you will have to attend the well baby clinics and pediatric clinics also, right? My presentation is not stuck, right? You all can hear me and the thing is going smoothly?
Yes, all going smooth, Kaushini.
Right. Thank you. Right. So coming to the ward setup, you will have in a ward, you may have an HDU, that is a high dependence unit, an acute side, a chronic side, a diarrhea side, and an isolation, right? In these little cubicles or separated units, you will have to go and take the daily rounds. In that aspect, you have to be familiar specific to pediatrics about the BP cuff sizes. Like you cannot use the same size BP cuff like in the adult wards to the pediatric patients, right? You have to know how to use that, the 2/3 of the arm length and all of that. You have to be familiar, and you have to use the right BP cuff. Otherwise, the value will be wrong and your management will be affected. Saturation probes are also the same. Like for the newborns, there will be this tiny little thin one, and for adult, I mean, not adults, like older patients, you can even use the adult probe. Height and weight charts are also there. You have to familiarize with them. They'll be available in the CHDRs. Or the WHO charts after 5 years of age, that will be available in the ward. So when you go to the ward, you have to familiarize yourself with these things, where these charts are, where these apparatuses are, where the different cup sizes are kept, because it's not always that you will be accompanied by a very cooperative attendant and a nurse when you're taking even a BP, right? So you have to know your ways around the ward. Ideal body weight charts are also there. Like I said, BP charts. Then dengue management national guidelines. Every ward has that book, usually. If it's not there, just at least have a PDF version of it saved in your phone. Then what we commonly call the poison book, that is written by Professor Ravindra Fernando. That's available in every ward, right? So like I said, this is the CHDR, and that's the marked the chart, height against weight chart, right? Sorry, weight against age chart. And these are the blood pressure charts, the normal blood pressure for the age and the height of the patient, right? And then you have to take the 50th and the 90th centile as the normal. Anything above the 90th is pre-hypertension, right? So I'm sure you learned these things. I'm just going to skim through those, okay? That's the blue one is the national guidelines for the management of dengue fever. And the other one that you see in red is the management of poisoning, the book written by Professor Ravindra Fernando. These are the ideal body weight charts. They are available in the national guidelines for dengue fever management. I think the last few pages have these annexures. Then coming to the daily status and clocking, right? You admit patients between 28 days of age to 13 plus years, 13 plus few months even, like you have to admit in a pediatric ward. It's advisable to start clocking and seeing the patients who have been handed over to you by the previous shift person. Say, obviously you're going to start your routine clocking with the HDU now. Just imagine there's a patient with like low urine output in the chronic side. If you are to just take the rounds mechanically, then come to that patient, by that time, a significant amount of time may have elapsed. So it's better to start over by seeing the bad patients that you were handed over to. You go on with the routine clocking, and you take history from the bystander, right? Imagine it's a new admission that you are clocking for the first time in the board. Then if you think that the bystander's history is not reliable, you just write it on top that the history is not reliable, query reliable, something, so that your history doesn't look like something funny at the end of the hospital stay of that patient. Because sometimes, like I said, patients don't always present with the same bystander that they will stay the rest of the days for, right? And then you go on with the routine examination. Depending on the history, you do a focused examination, BP cuff sizes, saturation probes. Like I said, everything differs with each patient, right? And drug dosages, I cannot emphasize this enough. You have to be going through the BNF, right? Like there will be this pediatric BNF in each ward. You have to know how to calculate the doses. If you're not sure, you can ask your senior, like this shows this value, but like I'm not too sure how to calculate this. Just be very thorough with the drug doses. And like, no matter how many times you check, sometimes you forget. That's all right. Like I used to have this tiny little booklet with like these common drugs that we prescribe. Oral is say cefuroxime, oral is, it's always 15 milligrams per kg. IV is 30 milligrams per kg. Augmentin is the same. Clarithromycin differs. So like that, like, so that I don't have to refer the BNF all the time, I copy it from the BNF. You can carry something like that, but don't just haphazardly check online like unreliable resources and then just prescribe, right? And drug charts, when you're doing your daily rounds, always optimize the drug charts. Like, say a patient presented with vomiting, and somebody has added domperidone, and on day 5 also the child has stopped vomiting and still the domperidone is going on. So you can withhold those drugs, because these are children. We don't really prefer giving unnecessary drugs, like even a PCM. It's only what is really necessary we have to prescribe, specifically for pediatrics, right? And you have to remember to order diets. Like, I don't think we order diets for any other adult categories of patients. In other words, I've not seen this much. Say you detect pallor at the first clocking, so you can just add some food items that you think will be beneficial for this child, or like a malnourished child. You can add eggs, like on the margin of the BHT, you can write eggs and, banana, then 2 yogurts per day. Like that, you can order a diet, so that the ward nurses, there's a diet clerk who comes daily to the ward. That clerk notes this down and gets them from the kitchen for the patients, right? As an HO, that is your duty, right? It is your duty to order diets. Or if you don't think that this child needs a special diet, you can just put normal diet. There's a coding system, S1, S2, something is there. I don't remember exactly right now. You have to ask the nurses of the ward and just order the diet. And you have to remember, we don't prick unnecessarily, right? Like, say, will you, adult patients, of course, we do count and CRP every other day if they're on IV antibiotics. But like these patients, if they are clinically responding and there are no high fever spikes, even on the 2nd day or the 3rd day of the IV antibiotics, we don't prick unnecessarily, unless like the consultant asks you to order, right? So try to minimize pricking as much as possible. So that is another difference between these adult wards and pediatric wards. And also in the wards, be an active participant in the discharge criteria and the discharge advices, because it can go a long way. Say you are discharging a patient with febrile fits. That's a classic example. You can tell the mother, you can reassure, like, this is a very common, it's a very like a very common and very prevalent condition in children who are less than 5 years. But the next episode, you as the mother can prevent it, right? You can tell them that when the fever spikes and when the fever kind of breaks, those are the risky times for fits. So when the fever spikes, make sure you have a thermometer at home. Make sure that you have always paracetamol syrup at home, and you know the correct dose. When the fever rises, you check with the thermometer and you give the right dose, right? You can prevent the next fit. And obviously every mother will want to follow these advices, and you can even prevent another unnecessary admission, right? And you can ask them to always carry a thermometer and like a paracetamol syrup bottle, even if they're going on a trip or something. So those advices really do matter. In the ward setup, the skills that you can attain are IV cannulation, right? IV cannulation, this is one of the best places to learn, I would say. Oops. Because I personally learned some of my cannulation procedures from the pediatric ward, because these pediatric ward nurses and the SCBU or the PBU nurses, they are the best people in any given hospital. With the I would say, best people to cannulate anybody. Because if you can cannulate a neonate or a pediatric patient, it's a given that you can always cannulate an adult too. Even a difficult cannulation in an adult, you can, because you are that well skilled. So I used to go and not in my first few months, say the 3rd or the 2nd and half, 3rd month onwards, I went and asked the nurses, Miss, how do we do this? I want to learn. Then they loved teaching. They taught me every step of the way. And I asked to cannulate every new admission, right? And it is a challenge, I'm not saying no. You need 10 people to hold the child, and you are still learning. So I mean, that's one of the hard ways of learning, but I would say it's really worth it. And another skill is to detect a sick child or a deteriorating child very early on, right? Because these pediatric patients, like I said, unlike the adults, they will show clinical improvement very fast or clinical deterioration very fast. So you should be able to detect. Daily you see the same patient, right? So daily, that too thrice daily. So you can see from morning till afternoon, and then in the night rounds, you can see the child has gone better or worse. You can easily see them. So that's a skill that you need to learn from these pediatric wards. Other one is the LP, lumbar puncture. You will get this if you're keen enough, because many children come with suspected meningitis, and we do LP, lumbar puncture, in the wards. So that is another skill that you can gain. Make sure that you ask for these, that you're proactive in asking for these skills in the wards, right? And of course, history taking in a very loud environment. The child is crying, the mother is sometimes crying, the nurse is yelling at top of the lungs to calm the mother and the child, and you are asking questions, nobody is cooperative, that too is a skill, to keep your calm in that sort of a stressful environment and elicit what you want from the patient and the bystander. That's a skill too, I would say, because even now I've seen a big difference between like medical officers who have done pediatric appointments and who have not. Like, at the moment a child starts crying, we still want to go and ask the mother what has happened, rather than thinking, oh my god, the child is crying, why is the child crying, right? So I've seen MOs going like, it's so loud. Some people just don't take pediatrics because they cannot like handle crying babies and whatnot. So if you are given this, or if you have chosen this appointment, I think that's a skill that you learn, and that's for life, right? Always have a smile, even though the child is crying and hates you for the rest of the stay too. And coming to the next setup, that is the PBU, or the special care baby unit. Daily status and clocking, you have to make sure that you change the footwear, wash hands, and get into like a sterile gown. May not be the routine practice at every place, but these are guidelines. Like every station may not offer you sterile gown, but it's a good thing to request. And I think like even on a first day, you can like impress your seniors if you kind of like request, wash your hands, and then request for a sterile gown at the PBU, because that is proper care. And you can familiarize with different fluid requirement calculations and phototherapy charts. Those are like otherwise known as SBR charts commonly. That's what it is. That is serum bilirubin charts, right? Because these are only found at these, they are like very specific to these neonates. So prior to your appointment in the PBU, you have to go and ask the staff or the SHOs, like, where are these charts and how do you calculate fluid for these neonates, because it depends on the day of life. Day one, a normal birth weight child requires a certain milliliters per kilogram than a day two child, right? It's different. Routine clocking, like I said, you start with day of life, like day one up to say 11 p.m. if the child was born 11 p.m. yesterday. And then you start with the problem list, daily status, examination, and then you have to handle the non-infective side of the PBO, the SCBU first, right? Again, go for minimal handling, right? And this is the chart that I was talking about, fluid requirement, the weight, the age. If you can see my mouse pointer, this is the day, and then the fluid requirement, this is the birth weight, right? Birth weight, if it is like 1.5 to 2 kilogram, in between that now, day one, you will need 60 to 80 milliliters per kilogram per day. So you have to multiply with that, and then that is the daily requirement. Then you have to give that fluid quota in fluid, even breast milk, breast milk, not breast milk, EBM. If the child is on exclusive EBM, you have to calculate by this and then prescribe it, right? This is the SBR chart, the well-known SBR chart. This is it depends each child's number of weeks of gestation, each, like, the chart differs, right? Say the POA is 37 weeks. This is not the chart that you have to use. So you have to be very cautious. And a copy of this will be attached to each VHT if the child is jaundiced. And I'm sure, like, it's a big process to teach you how to use this, like, but make sure that when you go in the first day to PBU, ask someone how to do this, because you will get calls in the middle of the night, Dr. SBR mecharai, and then you have to calculate, mark it, see if it's well below phototherapy line, or if the child needs exchange transfusion, which may even need you to go on a transfer, right? Skills to attend the PBU, I would say IV cannulation first. Again, I asked to cannulate even there, right? Because it was a totally different challenge, not seeing the cannula, the vein at all, right? You cannot see. Basically, you just cannot see sometimes. And so these nurses will teach you how to do that. And they are actually real pros in doing that. So you can learn from them. Umbilical vein catheterization, again, specific to neonates, you can ask to assist in the first few days, then ask to put it alone if you're confident from your SHOs. Neonatal examination is another thing that you will learn here. You know how to measure the AF, that is the anterior fontanelle, and how to detect any murmurs. Murmurs, of course, even in an adult, it's quite difficult to hear in the first few years of your career, but then as you go on with the PBU appointment or the postnatal appointments, you will start to hear a loud S2, right? Loud S2 always signifies what? Pulmonary hypertension and all. So you will learn those skills slowly with time. Try to auscultate every baby, and then that's how you actually pick up a loud S2 and all, loud P2. So yes, those I would say are the main skills, except those going through those charts and calculating. PHO duties, again, something very important. You will be called for emergency sections, elective sections, and normal vaginal deliveries too. But then again, not all routine electives and normal deliveries, I don't think you will be called. We were not. I don't know if it depends on the station, but for emergency sections, you are called for. So when you get the call itself, just make sure that you ask, unless it's a nurse who is calling you, which shouldn't be the practice, I think. Another HO should call you, right? Doctor to doctor communication. So you have to ask the POA and the, the indication, because it all depends on the indication. Why this? Do you suspect fetal bradycardia? Is that why you're doing the emergency section? And you have to attend like immediately, right? Whether it's a category 1 section, category 3 section, right? So you have to ask those immediately, and then like, you may have to alarm your on-call SHO as well, because if it's like a fetal bradycardia and it's your first few days of your appointment and you are not too sure how to resuscitate, you will have to tell the SHO, right? Later on, otherwise, if you don't call the SHO is bound to say, you didn't even let me know. No. Like, if you're not confident, you should let me know, right? For everything, because these are very sensitive patient groups, right? Neonates. The mother has carried the child for like 9 months. You don't want to lose the child after birth, right? For any mistake. So like, just think of it that way and just be well prepared, right? At all given times. Wait. I can't go to the next slide. And when you are called for an emergency section or like, PHO duty, you have to wash your hands, prepare the warmer, switch off the AC, check all the equipment, laryngoscopes, oxygen supplies. Usually the oxygen supply doesn't work. I don't know why. In the labor room, in the neonatal resuscitation station, I found many places, either the warmer is not working or the oxygen supply is not working. So I have to check these things beforehand, right? And then you have to skim through the mother's VHT to detect things like GDM. Then, of course, you have to check a CBS of the child, of the baby, right? So these things you have to go through the maternal VHT to find out any maternal conditions that may affect the neonate. You have to be, obviously, it's a given. You have to be very thorough with the neonatal resuscitation algorithm, head neutral position, keeping warm, head neutral, all of that. You have to be very, very thorough with. If not, please call your SHO. And you have to clock everything retrospectively. You just write the name, your name, designation, time, and date, and start writing by saying retrospective clocking, because you are attending to the baby first, and then only you're going and clocking, right? Even if you have to give CPR and that whole like resuscitation algorithm, you do that first and then come and write retrospective clocking. Make sure that you write that, because everything matters. All this timing and everything really matters in these PhDs, right? And skills to attain as a PHO would be neonatal resuscitation. You can detect congenital anomalies, things that may have been missed in utero, you might be able to see, right? Like right in front of you. And neonatal intubations, sometimes, depending on your, I wouldn't say luck, depending on your, it's an opportunity too. But sometimes, say like there's a stillbirth or something, sometimes the SHOs might ask you to intubate and practice on like the dead neonate. It really depends on the situation, but that is a skill that you have to attain to, right? Postnatal wards, I'll just go through very quickly. You do the routine neonatal examinations, and either SHO or you will have to fill the CHDR, that neonatal examination columns. And you can be actively involved in feeding optimization. You can give some advice to these mothers who complain there's Dr. Kirine, right? Or like, I don't know how to breastfeed properly. So you can give your advices and optimize that. If you can, just go to the LMC, that is Lactational Management Center. Every hospital, every hospital with a postnatal ward has this. So it's a really nice place to visit and see at least once. Just go. They are like, they like, there's a particular nurse who gives health education to these mothers about attachment, latching. Then for mothers with low breast milk production, they give like a lot of back massages, hot fermentation. So all of that, it'll be worthwhile knowing that as an MO also. Like here in this particular hospital that I work, like I found those little advices I've overheard even very useful, right? And then postnatal wards, another thing you'll do is you have to detect these babies who require follow-up, like say a very soft murmur that you have heard on day 1 of life. You will just ask them to review in like 6 weeks to see how the murmur goes, like whether it has worsened, it's still there, it has resolved. And well baby clinic reviews, you have to put the child for a well baby clinic review, WBC, right? You may be called for tachypnic babies, low CBS babies, unresponsive babies, babies who have not passed urine, who have not passed what do you call the stools, like so these calls might come in the middle of the night saying, doctor, the baby's tachypnic, or a section karapu amma baba is tachypnic. So that is actually, you have to attend immediately and do what's necessary. Like that is usually taken as an emergency, because pulmonary hypertension or like even neonatal pneumonia, like anything can lead to tachypnic conditions, right? So you have to attend immediately. Coming to the pediatric clinic, you have to clock the red numbers usually. Red numbers are the first visit patients, right? They have very first time in the clinic. So you take a very short history and do a focused examination. And you have to present to the consultant, not to anybody, like, not to an SHO or anyone. So when you go to the consultant, it will be really nice if you have already checked, like say, the inhaler techniques, or you have given the proper feeding advices or the dietary advices, things like that, before the consultant starts to advise on them. So it will save some time to the consultant, and they will be, even your seniors will be happy that you have actually looked into those things in the clinic, right? And well baby clinic, again, you have to clock the red numbers and present to the consultant. You have to check all the growth parameters, like the weight today, the length today, and the head circumference. You have to mark all of those in the particular areas of the CHDR. check for development, like is the child smiling at you now? All of those, the 4 main domains. You have to check all of that and detect for any abnormalities, and even examine for murmurs, and then check why they were referred to the well baby clinic. Not every baby will be put for hospital follow-up. No? So that, and that's about it. Like I hope I just gave you the very most important bits. I didn't go into any theory. I hope this was helpful, and I think I should thank Ishfak for giving me this little opportunity to share my experience with you. And I actually wish we had seniors like Ishfak, who arranged something, because we were totally clueless. We were just released in these wards, and now you're an HO today onwards, start work. That's all I knew. So then I didn't know what to do, where, like, well, baby clinic, Nangi, well, baby clinic, kada, just go. I don't know what to do. Like, go and see what, like, and then the mother comes and sits with the baby. I'm like, oh, now what do I do? Right? So why did you come? And, then I have to like ask the midwife, ask the SHO. So it's a lot of hassle. If I had like a small idea, this is what you do, this is what you do, I think that would have been really helpful. So thanks, Ishfak, on behalf of the interns for listening here. Right. Thank you and good luck.
And thank you, Kaushini, and thank you, Sumaiya, for accepting the invitation and making sure that you share your experiences. Now, like you said, when we started, when we started our internship, we were just put in the middle and expected to work like as if we knew. So that was very stressful, and we had a lot of expectations going on. So yeah, so I would want to give the chance to the participants to ask some questions from Kaushini or me or Sumaiya regarding anything you want to clarify, anything you still have some doubts. You can either type the question or you can raise the question with unmuting yourself. Anyone having question? I'm sure you'll have tons of questions.
Anything at all, just ask.
Just feel free.
Because we had tons of questions and we had no one to ask.
Yes.
Y'all are lucky that y'all have seniors like this who took their over their time. Some are really overworked, but still took their time and to explain all of this, to give an idea. So if anyone of y'all have any doubts, I can clear it here.
Where's the chat section? How do you check it?
Right next to participants? No, there are no new messages.
All right.
Okay.
If so, shall we call it a day then? I'm assuming no one has questions. And once again, thank you so much, Kaushini. Thank you so much, Sumaiya.
Thanks, Ishfak.
And thank you.
Quick question. Yes, Danush. Yes, you can ask. There's a question on the chat. Super nervous about thinking about the first day. Would the seniors be kind during PHO duties? Depends on your luck, I would say. Like seniors, okay, it's a direct message. Is it all right if I just talk?
Yeah. Please go ahead.
Yeah, a participant is asking, Suparna was thinking about the first day, would the seniors be kind? Well, it depends on a lot of factors. I think, like, considering it's the first day, yes, the seniors are supposed to be kind. If they are not, I think that's a problem of theirs, no? I mean, these new juniors come, and if you're mean to them on the first day, that's actually a personal problem of the SHO. But otherwise, mostly they are nice. If you can just be clear with your communication, like, it's my first day, I'm nervous. Can you please come with me for my first PHO duty? Kiela, I hope if you're kind, maybe they will come with you, depending on the workload and whatnot. Yes, so my answer is yes, usually they are kind. During PHO duties, can we ask the SHO to help? On the first few days, yes. Usually it's an HO duty, unless the neonatal indication for the delivery is quite bad. Say like a PH mother, so then the child will be anemic at birth, right? So then like you have to be very careful. I think in those cases you have to ask the SHO to come. Otherwise, say a GDM mother on like oral drugs and giving birth, so they are expecting a large baby. So you can go and attend, and anyway, just alert the SHO all the time. Like even at 3 a.m., there is a section. I am called for this. This is the POA. This is the indication for section. I'm going. Okay, and if there is any complication, I will call you. Tiela, you go. So that's fine. You can ask the SHO to help. Yes, routinely in the first 2-3 times, and then onwards ask for help if it's really necessary.
Yeah, actually, you can ask your immediate seniors, such as the HOs from the other batch who would have come before you. Just ask them first and then go for the SHO. So some SHOs get irritated when you try to disturb them always, but at the same time, some are very friendly who will even write discharges for you.
And it all depends, like example, my experience in internship and the experience I'm seeing now with my interns in Candy. It's like when they come on their first few days, the first few days when I'm doing my rounds, I actually do the rounds with them. Because normally they have to have a skill to develop a dynamic problem list. No? So obviously I can't expect it from them for the first 1 week or 2. So what I do is I do the rounds with them so that, I teach them. So this is how you get the problem list. Now you see here, now she is tachypneic. You see here, now there is a carbon dioxide retention. See, like that active sort of teaching is what a junior wants. But there are instances where sometimes you may not get it, but don't let that affect you. I mean, that is what you have to think. Not everywhere is a smooth ride. There can be roller coasters also. So just be brave and be ready for anything, and somehow finish this 1 year. And trust me, after you finish this 1 year, that will be a memory which you'll never forget, and an experience worth.
And make sure you don't repeat that for your juniors. That is the important.
That's a very good message, no?
Because we suffered, we must not make our juniors suffer.
That mentality has to drop at some generation. So just make sure you are an active member in that.
Yeah.
So any more questions? Right. I think there's no question. So thank you so much for joining this webinar, and I hope everyone was able to gain something out of it, and wish you all the best and congratulations, you've made it. And this
Congrats,
is a
guys.
milestone, and congrats, and enjoy every single day. And yeah.
Yeah, thank you so much for everyone, and please subscribe the Medicable Forum. You all can have updated guidelines and all those. Yeah, I wanted to mention there is a post on CTG, so it will give you a good clear this thing of like what and not you all should see and all of those things. So just subscribe it, then you all will have good updates.
Okay, so let's wind it out for today. And thanks, Kaushini. Thanks, Sumaiya.
No worries. Bye. Bye, everyone. All the best.